Je sais qu'on est fatigué.
I know we're all tired,
Les meilleurs à la fin.
but the best always comes at the end.
Et les meilleurs, c'est les maladies évitables
And the best
par la
are
vaccination.
diseases that can be avoided
Qui devrait
with
amener
vaccination. This notion
parce que
brings lots of hope
ces groupes de maladies
because those groups of
lorsqu'on a un
diseases
vaccin
that
efficace,
can be avoided when you have
et
an
on mène
efficacious
les
vaccine
activités de vaccination de manière
and you carry out the
contrôlée,
immunization campaign
on
in a
arrive
controlled fashion,
effectivement à les éviter.
we do manage to avoid those dreadful
Ces
diseases.
maladies
And yet,
sont encore malheureusement d'actualité.
those diseases are still striking very much, in particular measles.
En RDC.
Measles in DRC.
En RDC où malgré
In DRC, where despite intense immunization campaigns, the measles are still around.
tous les pays des plus de
They
5
come in epidemics and outbreaks,
Lorsqu'on regarde les 16 premières semaines de l'année,
like every 5 years. When you look at the first weeks in the year from January until the 2nd of May, our health centers reported more than 40,000 cases of measles with 943 deaths. That is a lethality of 24%. The outbreak affected a health district in 21 provinces out of the 25 provinces in DRC. So you see the scope of that disease that could be avoided with vaccines. And more than 70%, 72% of cases of measles are children under the age of 5.
La majorité de ces cas arrivent
And the majority of those cases occur in health areas that are difficult to get to.
la géographie,
Access is very difficult because of the geography, the terrain, or also because of security problems, which raises the problem of diagnosis.
des diagnostics et la
As
clé
you know, diagnosis is the key,
à toute intervention en santé.
the cornerstone before any public health intervention. And for infectious diseases, diagnosis opens the way to management of the disease and prevention. That's why in DRC, with MSF, Epicentre, and INRB, we reflected on that big question: how can we improve the diagnosis,
Améliorer la prise en charge et la prévention.
to improve the case management and prevention? The first thing we did was to set up a laboratory for measles in Lubumbashi, the second largest city in the country,
Les épidémies
where
la rougeole
measles outbreaks
Donc à travers ces projets
occur regularly. So through this URGP project,
ces laboratoires
it's called URGP, we set up this laboratory in the big laboratory of public health of the province. And we're happy to demonstrate that this lab is working very well, and it helps us to make better diagnosis. But it's a very big country. There are locked areas, locked-in areas, remote from everything. So we have to be innovative with our solutions. And that's why we thought of filter paper
et transporter
to collect and carry and transport blood samples so as to improve diagnosis. But we have several health districts
affectés par la rougeole.
that are affected by measles.
de santé qui
So we need to know
qui répond
what
pour lesquels on doit réagir.
health district is the most urgent to react in, to respond in.
Donc il se pose la question sur la limite.
And also we try to spare resources. So we wonder about the threshold of epidemic alert.
Je vous amène en RDC et un peu au Niger.
So I'm now taking you to DRC and a bit to Niger to address those two questions with two presentations. The first one will be done by two persons that I will now introduce. First, Céline Langendorf. She's a pharmacist and a biologist. She joined Epicenter Paris in 2011. She's currently involved in various clinical vaccine trials and in studies on resistance to antibiotics. She coordinates the research lab of Epicenter in Niger, as well as in Uganda. I'm not blaming you. Nobody is perfect. It could have been in DRC, though. The second presenter is Birgit Nicolai. She's also a biologist working at Epicenter since 2019. She has a PhD in molecular biology and a diploma in infection control. Since she joined Epicenter, she is a great addition as a support during measles and COVID epidemics in DRC. Birgit's research is on how to improve prevention strategies and response strategies to measles outbreaks in low or medium-income countries. We talked a lot together about those projects, and now I get to see her in real life, so I'm doubly happy. You have the floor, ladies.
Merci pour l'introduction.
Thank you for your introduction.
Hi, everyone. We would like to talk to you about the challenges we are trying to address on sample collection and laboratory procedures for measles biological confirmation and seroprevalence. While case confirmations is most of the time not necessary for case management decisions, the measles outbreak response relies on the timely biological confirmation of outbreaks to facilitate a vaccination response. But in MSF settings, most of the time in remote areas with limited lab capacities, we may experience delays in outbreak confirmation. On the other hand, seroprevalence estimates are necessary because of unknown real immunization level of the population due to unreliable vaccination status and disease history. Seroprevalence estimate can help plan vaccination activities by identifying pockets of low immunity. In addition, seroprevalence can help evaluate our vaccination activities. We can quantify if immunization levels in the population are sufficient to prevent epidemics. And we can also quantify if we are really targeting so far non-immunized children. To answer those questions in our context, we ideally need to use blood samples that are easy to collect without invasive procedures, easy to transport, meaning stable in time and high temperature, and we need a laboratory that performs reliable and accessible serology assays. If we want to biologically confirm cases of measles, the serology assays are based on IgM detection that increase shortly after the onset of symptoms. IgG antibodies gradually increase and become detectable for several years after infection. And IgG are also the antibodies that increase after vaccination. So IgG detection is used to estimate seroprevalence, either after natural measles infection or vaccination. For us, serology assays present the same challenges, regardless of the type of antibodies they detect. Concerning these challenges on the type of samples, the WHO recommends serum or plasma as reference samples, but they have practical limitations. Concerning the type of assays, the reference method is neutralization, but this method is only applicable in highly advanced laboratories. So we need to investigate more acceptable alternative methods. Dry blood spot taken from a fingerprint is the most convenient sample, easier to collect and to transport at room temperature. But it doesn't seem so simple in practice, mostly related to the increased stability in field conditions and the lack of standardization. ELISA is the most accessible method in our interventions context, but lacks some standardization regarding the positivity threshold, the adjustment factor needed when we use DBS, and the correlation with seroprotection. So now, based on example of studies, we are going to discuss some of these challenges that we are facing with DBS and ELISA, and how we try to address them.
So for the biological confirmation of measles cases, WHO recommends the use of DBS samples where serum cannot be used. However, the performance of DBS may be worse due to the impact of environmental conditions on sample preservation. So we therefore decided to evaluate the performance of DBS samples under field conditions in the DRC. Suspected measles cases were invited to provide paired samples of DBS and plasma. The samples were transported to the laboratory using the regular transport mechanisms, where DBS were shipped at room temperature and plasma at 4 degrees. Both sample types were analyzed using a semi-quantitative IgM ELISA. So here you can see the preliminary results of 148 participants. So while 53% of the participants were diagnosed positive for measles based on plasma, only 42% of participants were diagnosed positive based on DBS. So this means that DBS had a sensitivity compared to plasma of 84%, so meaning among participants diagnosed positive based on plasma, only 84% would have been diagnosed based on DBS samples. So when looking at the sensitivity of DBS over shipment delay, you can see that the DBS sensitivity decreases the longer it takes for the samples to arrive in the laboratory. Moreover, we can also see an impact of the sample location, where areas that are difficult to access have a lower sensitivity of 72% compared to 95% in easy accessible locations. So as there is a correlation between the type of location and the sampling and the shipment delay, it is not possible to differentiate between the conditions at the moment of sampling and the delay and the impact on the sensitivity based on these results. So in summary, we can say that for the timely and efficient confirmation of outbreaks, DBS samples can be used if they can be shipped to the laboratory within a few days. So unfortunately, this means that DBS is not the solution to all of our problems. However, we will evaluate whether the performance of DBS can be improved when shipping the samples at 4 degrees. Now moving on to the challenges we are facing for the interpretation of ELISA-based seroprevalence results. So here I will present the results of a study that was implemented to quantify the proportion of already immunized children at MSF vaccination sites during a preventive measles vaccination campaign in the DRC. So children were invited to provide a DBS sample and were also asked to answer a short questionnaire about vaccination history and history of previous measles infections. The samples were analyzed using a semi-quantitative IgG ELISA. Surprisingly, the seroprevalence was below 40% compared to reported vaccination of 87%, which may also be inaccurate. So the lower than expected seroprevalence raised the question whether the recommended threshold of IgG levels actually allowed to correctly identify immunized individuals. Moreover, we found no association between the reported vaccination status and the seroprevalence, where you can see here children with reported vaccination in dark blue and those without reported vaccination in light blue. And so this raises the question whether ELISA-based seroprevalence is indicative of protection for future infections on measles. So here we only use DBS samples. So we also are wondering whether these seroprevalence estimates based on DBS samples will need to be adjusted to match to the reference, the serum-based estimates.
And that's why, in another survey, we studied the impact of sample type on seroprevalence estimates. We wonder whether the quality of DBS under field conditions is comparable with DBS under laboratory conditions and serum. We carried out a seroprevalence study in the Diphtheria region in Niger, and we collected different samples among a subset of 156 children. 1 dBs obtained at home and stored at room temperature, 1 dBs performed in the laboratory from a whole blood tube, and 1 serum sample stored at -20 degrees. And we performed quantitative ELISA on these 3 samples in the same conditions. To the question, do DBS carried out on site under field conditions give similar results to DBS prepared and stored under lab conditions? The answer is yes. There is no significant difference in seroprevalence estimates given by both types of DBS. To the question, do DBS carrying on under field condition give similar results to DBS prepared compared to serum? The answer is now no. It seems that the DBS overestimate the seroprevalence since we consider the serum results as the reference. And serum sample give a seroprevalence estimated at around 50%, while reported measles vaccination or infection is estimated at 88%. So here as well, the seroprevalence is lower than expected, and we will discuss that later. To be able to estimate the seroprevalence from DBS results, we expected to have to estimate an adjustment factor. And that would enable us to estimate a seroprevalence closer to that obtained with the serum, the reference samples. So here are the seroprevalence estimated from DBS results after proportional adjustment to the serum results. So we confirm here it is necessary to validate the DBS methods against serum to get the adjustment factor or optimize the lab methods to provide the best correlation between both samples.
Okay, so in summary, for the use of seroprevalence for the planning and evaluation of vaccination activities, we can say that DBS is usable under field conditions. However, adjustment factors will be required. So we need to also evaluate whether these adjustment factors are consistent across settings or need to be re-evaluated in different settings. However, it is important to point out that the seroprevalence estimates based on ELISA, both based on DBS and serum sample, were much lower than expected. So this means that in the moment we can use ELISA-based estimates to compare between different settings, but probably we cannot rely on the absolute estimates. So before using ELISA-based seroprevalence to inform operational decisions, we'll need to evaluate whether these estimates are actually a good indicator of protection. So in conclusion, when evaluating the different alternatives for types of samples and types of assays, we can say that DBS is an appropriate sample type, both for the confirmation of outbreaks and for seroprevalence, if a quick transport to the laboratory can be guaranteed. For the use of ELISA-based seroprevalence estimates, we'll need to better understand the interpretation of ELISA results themselves before being able to use them really for operational decisions. And then finally, we will also need to evaluate how much precision is actually needed. So while efficient outbreak confirmation can be based on imperfect test results, seroprevalence estimates need to be more accurate to evaluate and plan vaccination activities. So we would like to thank all the teams involved in the DRC and the Niger surveys, and thank you very much for your attention.
Merci beaucoup, Céline et Birgit. Maintenant,
thank you very much, Birgit. I'm going to invite
Catherine est
Catherine.
épidémiologiste avec une formation.
She's an epidemiologist with a conventional epidemiology training, modeling infectious diseases and for data science. And above her work on measles, she's also supported MSF emergency responses. She was in the field and she also supported MSF remotely. And I give her the floor.
Merci Steve. Hi, everyone.
Thank you, Steve.
I want to talk to you about a simple alert system that's designed to improve measles outbreak response. Now, we all know and love alert systems, but they can be surprisingly difficult to design. And to understand why, I want to start with a little story, a story that begins, of course, in the DRC. Now, this is a massive country with more than 500 health zones, and one that faces a substantial burden of measles. And while MSF has always had alert systems in place, we have often found that we face far more alerts than we could possibly respond to, and that moreover, many of those alerts will turn out to be false. And so MSF asked the question, can't we do better? Is there not a system that would correspond better to our operational needs? And it was with that question in mind that 2 years ago, I got up here and we talked about a simple alert system, and we argued that that system could provide a more balanced alternative. Now, we will revisit what those results look like in just a minute, but for the second, supposing that they were wildly convincing, one of the first questions we might ask is, all right, but does that system work well anywhere else? And that's the question I want to focus on today. And to answer it, we're going to take a few steps. First, we're going to select countries that have differing epidemic profiles, so we can see if this system works well in diverse conditions. Then, we're going to identify admin level 2 outbreaks, admin 2 being those health zones in the DRC, from 2015 to 2024, using surveillance data from the respective ministries of health in those countries. And finally, we're going to evaluate the performance of this alert system against that retrospective data and in comparison to some common standard options. So beginning with that idea of selecting study countries, we of course will begin with Niger, with the DRC. Spoiler, the other country, sorry Steve, is Niger. Now the DRC, as we've already seen, is a high burden country and one that faces mass, often multi-year epidemics. To it, as you may have guessed, we will be adding Niger. Now this is also a high burden context, but instead of having multi-year epidemics, it shows high seasonality, with a measles season occurring every single year. Diving a little bit deeper into those epidemic profiles and finally seeing some numbers, here we can look at the number of weekly suspected measles cases at the national level in the DRC. Translating that into outbreaks, again at that admin level 2, we will find 683 in total. Now those outbreaks had a median size of 782 cases and lasted in general about 31 weeks. Doing the same for Niger, here we can really see that annual seasonality. We're going to find a total of 175 outbreaks, which are a little bit smaller, with a median size of 129 cases, and a little bit shorter, with a median duration of 21 weeks. Now that we have our historical data in place, let's finally define that alert system. Now, our alert system is based on a combination of weekly and tri-weekly thresholds of suspected cases, where that weekly threshold is simply the number of suspected cases in the current week, and we've considered a few options, 1 case, 2, 5, etc. And the tri-weekly threshold is then simply the number of suspected cases in the most recent 3 weeks, and again, we've considered multiple options. So for example, we could imagine an alert that will combine a weekly threshold of 20 with a tri-weekly threshold of 35. This alert will be triggered whenever I had either 20 cases this week or 35 in the most recent 3. Similarly, we could imagine combining a weekly threshold of 10 with a tri-weekly threshold of 15, etc. You get the point. Now this system is going to be compared to a couple options. And the first is going to be a common recommendation from the WHO, which will look for 5 suspected cases in a given locale within a single month. Now, locale is admittedly an ambiguous term, but with the data I have available for this analysis we're talking about today, I'm forced to evaluate it at that admin 2 level. The second system we'll consider is a common recommendation from MSF, which will look for trend, specifically an increase in the number of suspected cases for 3 consecutive weeks. Now, each of these systems will be evaluated against both positive and negative metrics. And today, the positive metric that we're going to focus on are the number of cases captured by response. What does that mean? Well, if we imagine an outbreak that had an alert triggered at a given moment, we're going to suppose that after that alert happens, there's a bit of delay, logistics, planning, confirmation, etc. All the cases that then arrive after this delay has ended are going to be our cases captured. Now, delay is, of course, context-specific, and for the purpose of this conversation today, we're going to suppose that it's 8 weeks in the DRC and 4 weeks in Niger. Our negative metric is then the frequency of false alerts, which is exactly what it sounds like. I have an alert, but then I have no epidemic. So putting all of this together, we're going to end up with a plot that you might remember from last time looks something like this. Now, just as a reminder, here, each of those circles represents a combination of thresholds. So this one represents 10 cases as our weekly threshold, mixed with 15 cases as our tri-weekly. Our vertical axis then shows us that positive indicator of cases captured, and the horizontal shows the negative of percent of false alerts. So here on the left, we're in blue. That means we're talking about the DRC. So let's go ahead and add Niger on the right. Now, one of the first things we might observe is that for a given choice of threshold, the DRC will generally capture more cases. At the same time, Niger will typically show a lower risk of false alerts. But thinking back to those epidemic profiles, this actually makes a lot of sense. Because in the DRC, we see larger, longer epidemics, giving me more time to capture more cases. But at the same time, we have very high endemic transmission, leading to an increased risk that those spurious endemic cases will trigger a false alert. And so indeed, in general, we find that this higher burden will typically result in a greater proportion of cases captured, but also in a higher incidence of false alerts. Turning now to our comparisons, let's begin with the WHO recommendation, which we would find captured 90% of cases in the DRC, but came with a substantial risk of false alerts, with 83% of them being false. Niger shows a similar story, capturing 86% of cases, while still having a 69% risk of false alerts. Indeed, the recommendation from the WHO has a performance that is very similar to our alternative system when choosing the most sensitive thresholds. More striking, however, is the comparison with trend. Here, we find that in the DRC, we would have captured only 52% of cases, while still having a 42% risk of an alert being false. Niger is no better, where we find that our system fails to capture even half of those outbreak cases. So what's going on? Why does trend perform so badly? Well, to answer that question, let's look at a couple of examples. And let's start with Mwenge in the DRC. Using the trend-based alert system, we would have found that this outbreak never triggered an alert. We can also pull an example from Niger, this time in Niamey, where once again, no alert is ever triggered. Taking now a slightly bigger outbreak, going back to the DRC, this time in Kunda, we find that finally, indeed, an alert does happen, but only at the very end of the epidemic. So what's going wrong? Well, what we see in these curves is that there is a high amount of volatility, meaning that an increase over 1 week and even 2 might then be followed by a temporary decline. And indeed, it is exactly this volatility that is characteristic of measles surveillance data, which makes trend based on raw cases an unreliable system of alert. So let's turn now from theory a bit more towards practice and spend the last couple minutes talking about implementation. So in this system, we have a lot of options, and we see in general that as we move up and to the right on that curve, we will have options that are more sensitive, ones that are going to prioritize capturing as many cases as possible. Going the other direction, we're going to have options that are more certain, which will really focus on minimizing the risk that an alert is false. But how do I pick where on that curve I want to be? Well, this is where conversations with our operational teams become so critical, and we will need to keep in mind factors like our operational goals. So let's say, for example, I am the Ministry of Health. I have a presence everywhere, and I want to be aware of anything that might be happening. Well, then, perhaps I'm going to want to prioritize sensitivity, and I'm going to choose an option that's up over here. But let's say instead that now I'm MSF, and I'm focused on emergency response. Well, then perhaps I want something a little bit less sensitive, but a little bit more certain. At that point, we'll also start to think about our operational capacity. And depending on what my resources look like in this moment, perhaps I will need to even further prioritize certainty. And of course, just as a reminder, the broader context will always remain critical, and this is only one tool. Additional factors such as requirements of laboratory testing, security concerns, and logistics will always remain a critical component of how a tool like this is implemented in practice. So how have these conversations gone in our 2 exemplar countries? Well, in the DRC, 2 threshold combinations were pulled out as recommendations, one giving an option that's a bit more sensitive and the other a little bit more moderate. In practice, these have been used in collaboration with a broader prioritization framework, such that that more sensitive threshold can be used in areas identified as having a higher risk, and the more moderate system can be used everywhere else. Today, these alerts are already available on the DRC surveillance dashboard and are updated weekly with the new data from the Ministry of Health. In Niger, we've also had 2 recommendations pulled out of our options. The first, more sensitive, and the second, once again, more moderate. But by contrast, these 2 recommendations in Niger have been combined to create a 2-level system. In this way, we can imagine an outbreak that transitions first into a level 1 alert and then potentially into one of level 2. Similar to the DRC, these alerts are now available on the Niger surveillance dashboard and are updated weekly. So in conclusion, we have developed a simple measles alert system based on a combination of weekly and tri-weekly suspected case thresholds. We have evaluated this system in countries with distinct epidemic profiles and found it to outperform common alternatives. And finally, we have considered how this system could be adapted to context-specific operational needs. Looking forward, we have now received additional funding to extend this analysis in countries with additional epidemic profiles, and we'll look at areas such as those with a lower burden of measles, as well as in areas that have more limited surveillance. With that, I will stop here, thanking all of my colleagues and communities that contributed to this research, as well as all of you for your attention. Thank you so much.
Merci à Catherine. Je pense que
Thank you, Catherine. If I had had this 12 years ago, I wouldn't have looked for a cholera epidemic for 3 days in the Congolese forest, an epidemic that did not exist. Now we are going to go on considering avoidable diseases. So sorry, Steve, but we are leaving DRC. And we're going to look at diphtheria. We know that there are still some epidemics, and this has been the case for some years now. This is a bacterial infection with fever, sore throat, and the formation of a pseudomembrane in the throat that can lead to respiratory complications and also blood and heart-related complications can also be associated with the presence of the bacteria. Now, mortality due to diphtheria epidemic varies depending on the context. It can be as high as 20% in under 5. When I say it varies depending on how quick you are with your diagnosis, whether you can access healthcare, and also the availability of antibiotics and anti-toxin. But first and foremost, it has to do with the vaccine coverage in the country. Since 2019, we've been faced with multiple cases of epidemics of diphtheria in countries where the healthcare system is fragile, in countries where, unfortunately, the vaccine coverage isn't good, is far too low. In 2023, MSF worked in 6 countries, if I'm not mistaken. 6 countries, and we had to organize response to diphtheria, a falling epidemic in Niger, Chad, Mali, Yemen, and Nigeria. Nigeria experienced the most severe diphtheria epidemic, and the very heart of the epidemic was in Kano, with more than 17,000 cases, patients seen by MSF. Now, today, 2 speakers, Yves and Franck, and they are going to describe the epidemiological profile of these epidemics that occupied MSF, and they will focus on Kano, where and you're going to hear about the characteristics of the epidemic and also about the challenges faced by MSF, with frequent shortage of antibiotics, also looking for DAT, and shortage of staff and internal challenges that put an incredible pressure on the healthcare system. Now, Yves is an engineer, a statistical engineer, and with a degree in mathematics. Yves is a member of Epicentre, and since 2019 he has contributed with his expertise to design innovative tools in order to improve the collection of data and the management of this data during epidemic. He makes sure that the data is available and can be exploited in order to allow for a more coherent and efficient response. Before joining the branch in Paris, he worked in the branch in Dakar, where he designed several surveillance tools. He is going to be seconded by Franck Allais, who has a PhD in epidemiology and with a very long experience since 2010 in humanitarian action. He is also head of the epidemic response in Ouaka, based in Abidjan. However, he used to be with the regional bureau in Dakar and worked on epidemic situations in Niger with MSF and Alima, and she was in Mali with MSF and Alima. So you see, she's seen the world. She didn't stay always worked for MSF, but she always come back. So even Franck, he always come back. Sorry. They have the floor.
Merci pour l'introduction et la présentation.
Thank you very much for this introduction. As Ismaël explained, there are 2 parts in our presentation. The first one is about the diphtheria epidemic in 2023, so a global overview, and then Franck will tell you about MSF Ouaka response, mainly in Nigeria.
Alors, ça a été bien dit en introduction.
So you were told about this as an introduction, but diphtheria is a bacterial infection that is most of the time airborne as far as transmission goes, with symptoms that are characterized by fever, sore throat, and pseudomembrane in the throat. You need bacteriological examination of lesions, and complications are usually seen affecting the peripheral nervous system. The treatment is DAT and antibiotics, and as far as prevention goes, well, vaccine is, of course, included in routine vaccination and very often combined with tetanus and whooping cough vaccine. Now, a bit of historical background. Between 2019 2010 and 2022, 85 countries reported diphtheria cases, mainly in Southeast Asia and Africa. However, since 2019, the major outbreaks were seen mainly in Africa. There's also a lower vaccine coverage in Africa versus other regions of the world. And in 2023, there was a major epidemic in Western Africa, mainly with 25,000 cases reported in 2023 and 5,000 cases in 2024. Now, this very strong increase is probably due to the lower vaccine coverage against diphtheria associated with the COVID pandemic, among other factors. In the 5 MSF sections, worked on 20 sites in 6 countries to treat 23,000 patients, i.e. 75% of all cases notified by the EMOH. So Nigeria was the most affected, with 17,000 patients treated by MSF, 5,000 patients were treated in Guinea, and 1,600 in Niger in 5 sites. MSF also treated cases in Mali and Chad, but there were far fewer patients. Finally, since the large epidemic in 2007, they've followed Yemen, patients in Yemen, and there's been a new surge in 2023. There may not be a link between all these epidemics, but the dynamic is interesting for Niger and Nigeria. Indeed, if you take a look at the graph here, and if you consider the domestic data, there are 2 similar epidemic profiles. Now, there's first a first wave, and then followed by a second one. And especially, you can see that the majority of cases are reported in the Zinder region in Niger and in Kano in Nigeria. So it might suggest for trans-border exchanges between the 2 countries. In the course of the epidemic in 2023, MSF focused its response on Nigeria, shown in green here on the map. However, in the summer of 2023, MSF faced a very strong increase in the number of patients, up to 1,000 per week, mainly in Nigeria, but also in Niger and Guinea. And then the number of patients went down in the course of second quarter 2023, though the epidemic went on in 2024. With this sudden increase in summer 2023, there was a shortage of DAT at global level. And this is why, during this period, MSF and also WHO and UNICEF tried to join their forces to find DAT and make sure that the allocation of DAT was equitable between the various countries. Now, within MSF, Epicentre had to centralize data from all sites. However, the sites collected different data with different tools using different Excel files. And in order to monitor the situation in real time, firstly, Epicentre asked MSF to agree on a dictionary, on a registry of diphtheria-related variables. Then the various Excel spreadsheets were standardized using Outbreak tools developed by Epicentre. And then Epicentre was then started to collect the data, and it was possible to design a dashboard to have a real-time monitoring of the epidemic and to compare the various indicators. And it is used it is also used to have a fair allocation of DAT between the different sites. Now, a few statistics. 3,000 patients, 23,000 patients were treated, majority of them women, adults, as you can see here on the age pyramid. But 66% were under 15. And there's an overrepresentation of women, probably because they are the ones who take care of the children.
y a eu 61% des patients.
61% of patients during the epidemic were hospitalized, and the crude fatality ratio was 8%. Normally, all IPD patients had to get DAT, but just one patient out of 8 could be treated with DAT, i.e. one hospitalized patient out of 5. And now I'm going to hand over to Franck to tell you about the results in this country.
Merci. Bonsoir à tous. Nous allons essayer.
Thank you, Yves, and good afternoon. Let's go to Nigeria together. And we're going to go to the state of Kano, where MSF Waka intervened for response to the outbreak, and we took care of most cases. Now, Kano is a state of Nigeria with 50 million inhabitants. It is the most densely populated state in the country, with about 44 local government areas. But the outbreak mostly focused on 6 LGAs, local government areas, and we can see that the outbreak actually started in the same local government authorities at the same time, pretty much. And yeah, there were 2 waves, 2 successive waves, which made the response a little bit more complicated. On this map, you can see that the Ungogo LGA was the one that was the most severely impacted. So for us, it's the epicenter of the outbreak. And this is exactly where MSF Waka was present before the outbreak actually started. Now, in order to respond to this outbreak that started in the 6 LGAs at the same time, MSF Waka set up 3 treatment centers in 3 hospitals, and each center was dedicated to one case profile, one specific case profile. Now, there were several challenges, and in order to face these challenges, MSF had to adapt its strategy. First of all, at the beginning of the outbreak, that's in January 2023, we started taking care of cases in a conventional way, based mostly on the experience that we had in Yemen and Afghanistan. So we set up a centralized management system in Murtala Muhammad Specialist Hospital. And all cases, no matter how severe, were actually addressed to this center. And then we implemented a referral system so that all cases could be hospitalized in that unit. And then the capacity of the center was exceeded despite an increase in the number of beds. They went from 30 to 80 and then 115. And following the increase in the number of cases, we opened a second treatment center in the infectious disease hospital, IDH, that was on week 17. But when we decided to open the center, of course, it did not solve all problems. So we made other really important decisions during the course of week 27. The first thing that we did was to decide to take care of mild cases at home. And the second decision was to also rationalize the use of the antitoxin, the DAT, and only use it for most severe cases. During week 34, we opened a third treatment center in Waziri Sheru Gidado General Hospital. Now, this center was meant to take care of the simplest cases, and it was more like a triage center to make sure that the other 2 hospitals, MMSH and IDH, would not be overloaded with cases. So this one was more of a triage unit to take care of the simplest cases. Now, I want to talk about home-based care. Why did we decide to implement this? Well, the first reason is that we wanted to actually reduce the burden on the healthcare system because there was too much pressure with the high number of cases that came to the centers. And the second reason is that, as you can see here, at the end of June, we found that the number of cases was going down. And we actually expected the outbreak to stop. And the teams and the MSF staff were already exhausted. And then all of a sudden came the second wave. So in that case, MSF had to adapt its strategy. And now we decided to only hospitalize the most severe cases, or the moderate cases, sorry, mild cases. And all cases, and only the severe cases will be hospitalized. All the mild cases will be taken care of at home. The severe cases are those with throat obstruction and respiratory difficulties. These will be hospitalized and the others will be taken care of at home. But home care, home-based care, is a difficult decision to make because we decide to take care of mild cases at home, and this must come with a certain number of measures.
Décider de prendre en charge les cas à domicile va être accompagné d'un certain nombre de mesures de sécurité.
It's the safety measures. So what we do is that we carry out a certain number of infection prevention activities at home. We also implement health promotion activities in order to increase the awareness of households and to make sure that they could receive home-based care cases, prevention therapy also for contact cases, and we also have a remote monitoring or follow-up on the phone for the next 10 to 14 days. What are the results that came out of this? Well, first of all, we were able to take 6,696 cases on home-based care, which is a total of 45% of all cases that we treated during the outbreak. And we also found that the profile of those cases was more older people than those who were hospitalized. The lethality was 0.6%, the CFR. Now, the cases which were taken care in the hospital would receive DAT. We know that DAT has already proven efficiency in the reduction of mortality. It can reduce mortality by up to 76%. And when the DAT therapy is started soon enough, it can reduce mortality, but also every day of delay in the implementation of the for each day that the treatment is not given, the mortality can actually be doubled. So that's what we found in a literature review. When you look at the data for the severe cases which were treated in the system, you find similar results. The longer you wait to implement the treatment, the higher the mortality. So 1 day later means that you have a 6% mortality. 2 days later, the mortality is 12 or 13%. So the data observed in the cases of severe patients were similar to what we found in our literature review. But the challenge with this outbreak was mostly the availability of DAT. On this graph, you see the proportion of patients that received the DAT throughout the outbreak. As I said, at the beginning of the outbreak, the majority of cases received the antitoxin. And then, soon after, on week 3, we found that there was a partial shortage of that. And so we realized that we would no longer be able to administer DAT to the majority of cases. And at the end of 2023 and during the first 5 weeks of 2024, we faced a complete shortage of that. And therefore, no patient received antitoxin during that period of time.
La meta-analyse et les protocoles suggèrent.
So the literature review and the protocols suggest that a serious case of diphtheria should receive at least 40,000 units of that. That's the protocol that we have implemented for severe cases. We took our inspiration from the experience that we had from past outbreaks. 60% of the cases that we received were serious cases, so they should have received that. And on this graph, you see that in 5% of 25% received a dosage that was lower than 40,000 units. Because, as I said, severe cases should receive more than 40,000 units. And in that case, 25% of them received less because there was a shortage. So we had to adapt our strategies and decrease the dose that was administered to the patients.
Je vais laisser la parole à Yves pour la conclusion. Merci.
And I'll give the floor back to Yves for the conclusion.
En conclusion,
as a conclusion,
on peut dire que on a vu
we saw that during 2023, West Africa experienced one of its largest outbreak, mostly in the state of Kano. In Nigeria, the outbreak is now declining, but it's still continuing in 2024. MSF took care of most patients during the outbreak, but we had to face constraints, especially resources, limited capacity of hospitals, and limited DAT stock. So, because of all these constraints, we started a coordination among MSF sections and also between the countries and the outside partners in order to, for example, better allocate the antitoxin between the countries. And in Kano specifically, MSF Waka implemented a certain number of strategies to face these resource-based constraints. For example, we started home-based care and suboptimal dosage for severe patients. There are still studies in progress to better understand the safety of those strategies and the efficiency of these strategies. Now, how can we better prepare for future outbreaks? Well, first of all, we have to increase the available stocks of DAT, and also we need to increase the response capacity in terms of production. We also need to invest in alternative treatments through research and development. And we know that diphtheria is a disease that can be avoided with vaccination. So the control of epidemics and outbreaks means that we need to have a better coverage of vulnerable populations. Thank you.
Merci beaucoup aux présentateurs. Thank
you. I know it's the end of the day. A lot of you want to have a drink, right? But we're going to take time to ask questions about measles and diphtheria. We have a lot of questions in the chat. We see that MSF is present in a lot of situations, but still a lot still has to be done. A lot of questions remain unanswered. We have implemented mitigation strategies to adapt ourselves, to reinvent ourselves, and all these models, to be able to predict things and to find prevention thresholds. These are key elements which allow us to make informed decisions and to know where we want to be in terms of resources. And Diphtheria reminds us of the indirect consequences of COVID. And we have to expect a surge of outbreaks in the years to come. If we have an emergency medical center, we still need to think about the means that we have to be prepared, to prepare ourselves, because we were surprised by the diphtheria outbreaks in 2023, and it still continues. So let's take the questions from the floor, and then there will also be questions in the chat.
Il y a beaucoup de mains levées.
I see a lot of hands. You don't want that drink so bad after all, right? I will start. I'm Alain for the Essential Drugs Access Campaign. It's a question about access, about diphtheria. With the data that we have, can we actually find how many deaths could be
imputé en fait au manque d'accès aux dates? Est-ce que c'est quelque chose qui est une analyse qui est possible?
Could be caused by the lack of access to the date. That's information that we don't have today. Thank you, Alain. I'm going to answer this question. I think that we have we still have to analyze the situation. We've looked at the mortality curve before and after, during the shortage period, and so far I can't tell you how many deaths might have been caused by the shortage in that. As I said, we have a lot of data on all the epidemics that we have to continue our analysis, and we need to continue the work. And there were so many challenges about the dates, but we still need to continue to analyze the data that we have collected.
I have two quick questions for Céline and Brigitte. One is do you plan to use the DBS, the freeze DBS? Is there any possibility that you thought, because I think you put that you could put in a cold chain. There was a discussion in the cold chain, but do you think that it could be the freeze part to be used? And the other one is for Catherine. Do you see a lot of intervariability when you go to level 2 compared to DRC and to Niger? I mean, sometimes when you see the curve of the measles curve in DRC, is a big one, but it's taking into account all the health zones of the country, while Niger, the population is smaller. So, thanks.
Yeah, thank you. Maybe to answer the first part of the question. So we are thinking testing transport of DBS at 4 degrees, so not freezing them, but keeping it in the cold chain. And it's mainly, I mean, there are still the practical benefits of having DBS samples. We also had a short questionnaire, so people really prefer the simpler sampling procedure. And we still would expect, even if the cold chain is not perfect, to have maybe better stability of DBS than plasma, and also over a longer time period. But this is something we are going to evaluate in the next step of the study. We have not yet looked at it. Thanks.
Catherine, do you want to take the question on the chat?
Yeah, so online we've received a question about the alert analysis. Are most of the data used health facility based or also community based? What is the expected effect of non or difficult access to health facilities due to patient payments imposed before an outbreak is declared? And would this influence the curve and possibly also the false positive rates? This is a really wonderful question, and one that touches on a broader challenge that we face when doing these retrospective analyses. Here, to answer the immediate question, what was the data used? The answer to that question is I'm using the national surveillance data. So here it's the data I get from the Ministry of Health, which is to say we're looking at health facility data that's then notified all the way up to that national level. In general, this will not tend to include these more community-based data collection methods that we might see in MSF line list. More broadly, when we think about the reason an alert system like this is constructed, we're thinking about the idea of how can I put an alert system in place that could act in concert with those routine data sources. What will this system be able to do in terms of the data that are available on a weekly basis? And because that's my goal, I do limit the data used here to that routine information. It is almost certainly the case that there is substantial under-notification in what we receive from those health facilities. And so it's very possible that if we were able to implement a version of the system that also aggregates community-based surveillance, it perhaps would work less well. My intuitive guess is that it probably would work, but we might need to change what those exact threshold numbers look like. So perhaps we would need to increase them slightly in order to have something of a comparable performance. In terms of the second part of this question, how would this potentially influence the risk of false positives? Here, I'm assuming when you say false positive, you mean false alert, but correct me online if I'm
false
incorrect.
Alert, I think.
Yeah. So to answer that, one of the challenges, again, with a retrospective analysis is my definition of a false alert is entirely defined by what I see in that historic data. It is almost certainly true that there are real alerts that did happen and they were never captured in that historical data set. So this specific question, do I imagine that had we included that community data, some of those alerts that in my data set are false would turn out to actually be true? Absolutely, but there's no way for me to evaluate that with the data that I have available.
Okay, thank you, Catherine.
Okay.
I hope that
Merci. Donc,
thank you.
Okay,
voilà, donc, mon intervention, j'ai une question et puis
I have a question and maybe a contribution to make about Céline and Brigitte's talk. To Brigitte, when you look at the results obtained in Niger, I think that the relative humidity rate might have an influence on the drying of the DBS. So I don't know, because we know the measles season is during the hot and dry season. So this is why we had those results in blood samples and in DBS also. So that's why I was asking the question of the season. And about Céline, I would like to say that for us at Cervès, we would like to continue the experiments to see how we can optimize the transfer times, because usually in the labs you can use desiccates in the transportation systems. Somebody talked about freezing. Well, it could be desiccated to fine-tune the drying system in the lab. We use desiccates, and maybe in the labs you need to have a desiccating machine in order to minimize the influence of the moisture content. And that's what I wanted to contribute. Thank you very much. Oh, well, thank you. This is very relevant. Indeed, when I talked about the type of place where we took the samples, we mostly thought about the conditions, and moisture content also was important, because we did collect the samples in late January, early February during the rain season. And when you talk about places which are difficult to access, also the sampling conditions are more difficult. And maybe it was because there was a higher moisture content. The second part of the study, where we're going to have part of the DBS that will be stored differently for transportation, maybe we'll be able to make the difference between the sampling issues and the transportation issues. And so we'll try to really make the difference between the two, to try to better understand and to identify and see how we can improve the conditions Maybe we're going to take 2 more questions. We have 2 people with a mic here. So go ahead. My question was about the use of DBS as well. As you said in your conclusion, in the CIR, we are working on a procedure for the transportation of samples. And after your presentation, I have 2 questions. The first is that you made a qualitative or quantitative comparison, because you said that all the positives in plasma were DBS positive and negative with control, or did you compare the optical density? Second question is about dilution. ELISA is a test, it is a titration test for which dilution is really important. And this factor usually depends on the starting concentration. So how did you quantify plasma on DBS versus the plasma in the tubes? Thank you. Thank you for these questions. Well, the first question is about the comparisons. We did quantitative comparisons. I'm talking about the study that we did in Niger, where we sampled DBS and plasma, and we made quantitative comparisons. We did calibration curves, and we had the titer of DBS and of plasma, and we compared the titration, which we then turned into positive or negative, depending on the instructions given by the manufacturer. The second question is a problem indeed, because there's the standardization of the use of DBS. Well, it's not standardized for the moment. So one of the key points is how much plasma is there in the blood drop that you analyze. So the assumption that everybody makes, because we have no other data, is that it is at 50% plasma in a droplet of blood, because it's 50% hematocrits. But it's probably wrong in the context in which we are working. And this is probably why we need to use adjustment factors or to optimize our dilution method and our dilution factor based on the serum. So what we did is that we took a dilution protocol that had been published in literature, we analyzed it, we got a result, and we used an adjustment factor on the basis of statistical analysis to come up with the serum values. We might have done method validation, that is, take the DBS and find how many microliters I should take from my DBS in order to get the same results as with serum. Once I have this protocol, I would apply it to all DBS in all my study, and I get the result. This part, this standardization, validation here part, is something that we very unusually do in our contexts, because it means that you would need to take serum and DBS in a subsample of children, at least 150 of them, in order to be able to do this method optimization. So we, in our labs, we are a little bit at the beginning of that, but we are working on it.
Merci, Céline.
Okay. Thank you, Céline. My name is Ousmane. I'm in charge of a health center in Niger. I have a question about diphtheria outbreaks. Now, you put it on the indirect account of the COVID pandemic. But when I looked at your map, among the 6 countries you presented, except for Guinea, all the other countries experience a great degree of insecurity. And the problems with the measles campaign might also be due to the overall context. In the 5 countries mentioned, there are many population displacements, and Guinea was hit very badly by COVID.
Le traitement orienté sur Ebola qu'au profit des autres
en tout cas de prévention. Je pense que
And I think a focus was made on treating Ebola rather than doing prevention. I come from Niger.
prendre en compte aussi. Merci.
I know the situation over there. Thank you, dear Usman. I let Frank and Eve answer that. And there is another question in the chat about diphtheria.
Merci, Suleiman, pour ta remarque. Oui, en fait,
Thank you for your comments, Usman. On the one hand, there are multi-factors to the origin of the epidemic. We cannot know exactly what are all the factors involved.
qui joue sur l'épidémie. Mais l'un des facteurs,
But one of those factors is the decrease in the vaccination coverage. There are several dimensions to that, of course.
merci. Je vais répondre par rapport à la question sur la mortalité.
Okay, the question about mortality.
Pour ce qui concerne la mortalité, nous avons
Concerning mortality, we say it's 0.6 for moderate cases that were managed at home. That's what we observed in our data. Then what we are currently doing, that's what's interesting, is that we are doing post-mortem autopsy to analyze what cases are really due, what cases of death are due to diphtheria. We talk with people who witnessed the death of the case, and this is done by the team of doctors, clinician doctors, working in the treatment centers and in the epidemiological center. Secondly, since we count only the deaths registered in the hospital, what we tried to do with Johnny and Etienne, we developed a protocol for a retrospective mortality analysis. And with that protocol, we'll try to assess a number of factors, look at the mortality within the cohort of children taken care of at home compared with those hospitalized. We developed a specific method for that. The second thing we're trying to do is to start from the results of the autopsy to look at the mortality in each cohort and when we didn't do anything, we'll check the mortality compared with the period when we did something. Oh, when we did the DAT, diphtheria antitoxin. And then we can compare. We'll have a baseline. We are still analyzing the patients' records, and inshallah, hopefully, some publications will come soon after that. We have a working group working on that. We have friends and colleagues in Nigeria doing research as well. Thank you. We'll take one last question, because then we'll have a summary of the day before we can have a good time with a drink. If you allow me, since I'm holding the mic, I'd like to know, among the number of cases that you managed, how many, and who were vaccinated, how many cases of relapse? Did you analyze that? A percentage of relapse. For diphtheria? We don't have the data to know how many cases of relapse. There are still many unknown variables associated with diphtheria outbreak. We were surprised. We had some problems with coordination. It took us several months before we had a standardized list to collect information. Today we have a robust database, so we can work more finely on some additional elements in order to better understand this outbreak and be better prepared for future epidemics, because we believe there will be future epidemics. Many thanks to all.